50% will have an associated fracture of the proximal phalanx, which could be avulsion fracture, or it could be a mild displacement of the medial aspects of the proximal phalanx bone fracture. So if you could see in this film, there are two types of fracture. One, in the red color mark, you can see that a tiny, very tiny avulsion fracture that is typical ulnar collateral ligament injury. That is one. And the second one, if you can see how much a chunk of the bone fragment came out of the medial aspects of the proximal phalanx. So this is quite easy to see it in the X-ray film, but the radiologist sometimes, there are plenty of cases that radiologists missed diagnosing the conditions in here. But as a role of a hand therapist, you may have access to see a film where you can close look at the bony fragment around there and then start managing as you wish, and discuss with your senior therapist or discuss with your referring doctor that this is what happened. Communication to the doctors, very, very important. Starting from the initial report to progress notes to the discharge notes, which explains the importance of professional interactions with the doctors and the therapists, where he can send you more cases. And also, in plain films, we can also see a SAG sign. SAG sign has also been used to identify UCL injuries. And this is where we need to understand that the ulnar sesamoid bone also sometimes gives you a false positive of a SAG sign, but it's quite obvious. On top of this film, you're also doing a clinical examination so that you know how lax the joint is. You can come on a conclusion of ulnar collateral ligament. Absence of the UCL allows adductor pollicis insertion to pull the PIP into volar direction, giving the appearance of volar subluxation. So it's very important to, in terms of observing the thumb in an initial assessment, you could see the thumb metacarpal feel like it's volarly subluxed, partially dislocated. That's because of that absence of the contraction from the ulnar collateral ligament versus a radial collateral ligament. There are some accuracy in a retrospective study that assessing a SAG sign can be a possibility of ulnar collateral ligament. And the another sign that we can see is a two-fleck sign, which is the adductor insertion as well as the stenar lesion. Two bony fragments are present, one obviously denoting an undisplaced avulsion fracture, the other less obvious, often missed, denoting a stenar lesion. This has not been correlated with other imaging studies or a surgery. Clinical examination on exclusion of surgical indicated plain films. Stress testing may help in a diagnosis, but it's a controversial, like putting a pressure on the ulnar side to see whether that can create a pain or a tenderness, or taking a plain X-ray under the stress loading. Also, an indication that ulnar collateral ligament you can pick up from there, but it's quite controversial because the patient is already under the pain and tenderness and swollen. If you do that stress testing, you are poking the pain a bit more, so which is the controversy. But we have other diagnostic methods available in here. I hope that is also available in our part of the world over there. So it's good to get all the investigation done prior to, on top of your clinical examination, before you are starting management on ulnar collateral ligament injury. Suggested that the stress test may convert a partial tear to a full tear. When you're putting a loading on top of the ulnar collateral ligament by testing it, that may be a possibility that you are tearing the rest of the remaining ulnar collateral ligament. but it is being dismissed in a recent cadaver study that it's not a possible situation because the client can pull the hand out very quickly and the pain start happening and the swell up and other conditions. In examination stress testing techniques or stabilize the MC, you can also practice in a classrooms or in a clinical area about stabilizing the metacarpal and apply a radial abduction force to see that in extension and 30-degree of flexion. The reason for checking it out in extension and 30-degree flexion is to check it out how much integrity of the proper collateral ligament versus accessory collateral ligament. And also it gives you ensuring no rotation of proximal phalanx. Do not rotate it proximal phalanx, but